wanted to know so that I could make sure that that got in there next year. All right, so vertebral column, we'll talk about the C-spine primarily today. Again, we'll go through T-spine and L-spine next week. We'll talk a little bit about T-spine today, but not just a whole lot, in as much as it pertains to the lower portion of the C-spine. We'll talk about T-spine. So the vertebral column forms the axial skeleton. It's centered for the most part in the mid-sagittal plane. You'll have patients sometimes that have scoliosis, which takes it out of the mid-sagittal plane. We'll talk about that as well. It is located in the posterior portion of the trunk. In the C-spine, it's closer to centered, but in the T-spine and L-spine, it's definitely in the posterior portion. The functions are that it encloses and protects the spinal cord, so every vertebra has a hole in it where the spinal cord goes through. It supports the trunk and the skull, and then it provides attachment for muscles, which are what all of these projections off the posterior portion of the spine are all about. These things that stick off to the side here, and the things that stick off to the back here, just muscular attachments. And we'll talk about the significance of every one of those in the anatomy portion. So, a typical skeleton, we're going to have 33 vertebrae, 24 true movable vertebrae, and then the sacral and the coccyx segments are fused into just basically one big bone that we're going to call the sacrum, even though it's individual bones, they're fused together to create the sacrum, and the same thing for the coccyx. The coccyx is going to be variable according to person by person. You may have anywhere from 3 to 5 coccyx segments. So they're composed of small irregular bones. Those are your vertebrae. There's 33 in early life, 24 being true, and then the rest are fused into 2 specific segments, being the coccyx and the sacral segments. So they're divided into 5 groups. So you got cervical, which is the neck, thoracic being the upper portion of the back, you got the lumbar being the lower portion of the back, and then the pelvic segments will be your sacrum and your coccyx. And you have 4 curvatures, and you can really break those down into 2 different types of curvatures. You got a lordotic curvature and a kyphotic curvature. I'm going to spin around and I'm going to kind of draw this on the backboard, and we'll talk about how we describe the different ways in which we describe the curvatures. All right. So you're going to see the questions come at you from a couple of different directions. It's either going to ask you for the lordotic curvature or the kyphotic curvature, and where the lordotic curvature lives and where the kyphotic curvature lives. And also, it's going to be asking you, there's some of your questions going to be asking you about concavity versus convexity. All right, so just definitions. Whenever we talked about chest x-rays, what was a lordotic chest x-ray? Leaning back. Exactly, leaning back. So think of lordotic as being a leaning back type motion. So kyphotic is, you've got a natural kyphotic curvature in your T-spine. Oh, when you're doing a lateral chest x-ray, you shoot a lateral chest x-ray, what you see is the chest and the vertebra kind of bow backwards like that. That's a little bit exaggerated, but you kind of get the point. You know, people are holding onto the bar and you see this curvature here, right? That is a kyphotic curvature. Sometimes people have compression fractures. Your older patients, especially osteoporotic patients, the vertebra will collapse. That's what you call a pathological fracture. It's a fracture because of pathology. The vertebra weakens over time. Cortex of the bone gets thin, and they just collapse. So what you'll see in an older patient is an exaggerated kyphotic curvature. You've seen older patients, they in their younger life, they walked around, you know, with good posture, and the older in life they got, the more they slunched over, right? It's an exaggerated kyphotic curvature. So the T-spine is a kyphotic curvature. The L-spine goes in the opposite direction. It's as if you were leaning back, and that is your lordotic curvature. So T-spine, kyphotic, and L-spine is lordotic. Okay, so that takes care of two of them. Those are the most obvious two. But it starts to go back around in the pelvis so that your coccyx is pointing kind of anteriorly. So what you got is a return to kyphosis in the sacrum and sacral segments. And then when we get back up into the C-spine, what you've got is a return to lordosis. Okay? So your questions will ask, what curvatures are lordotic? That would be your C-spine and your L-spine. Which curvatures are kyphotic? That would be your sacrum or your pelvic segments and your T-spine, or kyphotic, right? So the other way that it'll ask you is which one's convex and which one is concave. Well, first off, you got to get some perspective because both. Kyphotic curvatures are both convex and concave depending on which perspective you're looking at. So when we're talking about convex, just word association. Whenever you flex your muscle, what do you get? Does it dent? No, it bulges. So you flex and it bulges outward, right? So you flex your muscles and it bulges outward. So you got a bulge here, you got a bulge here, you got a bulge here, you got a bulge here. All right, so the head is up here and the nose is pointing that way. So what's anterior? This side. And what's posterior? That side, right? So the C-spine, where is the bulge on the C-spine? Anterior, right. So anteriorly, we've got convex, right? And on the L-spine, anteriorly, we have convex, right? The T-spine, posteriorly, is convex. And then the sacrum and the coccyx, posteriorly, is convex. Okay? So your question may ask, your C-spine is convex on which surface? That would be your anterior surface. The T-spine is convex on which surface? That would be your posterior surface. That's not enough. We've also got concave. So again, word association. You got a mountain. You got a hole in the mountain. What do we call the hole in the mountain? You can walk into it. You can go spelunking. What do you call it? A cave, right. So caves go in, right? So the C-spine is concave posteriorly, and it is convex anteriorly. The T-spine is concave anteriorly. The L-spine is concave posteriorly, and the pelvic segments are concave anteriorly. Okay? So two of those curvatures are in response to stimulus. Two of those curvatures are primary. Okay, you are born with this curve and this curve. All right, so you look at a baby, you're probably never going to see a baby's lateral T-spine and L-spine. You're just not going to see it. But you look at a baby crawling around, and what you'll see is their back is straight, right? You get up on your hands and knees, chances are you're going to have a little bit of sag in your back. So what you're born with is your T-spine curvature and your sacral segment curvature. You don't get a C-spine curvature and you don't get an L-spine curvature until you stand up. And the weight causes that. The weight of your head causes a C-spine curve. The weight of the rest of your body causes your L-spine curvature. So you got two primary curvatures, that would be these two, and you've got two secondary curvatures, and that would be these two. Okay? So a lot of stuff, that really kind of goes into this one slide to keep in mind. Convexity, concavity, primary curvatures, secondary curvatures, all of that you have to know for the test. There we go. And that's what it looks like. It's explained on the slide. All right, so the vertebra, each one of the vertebrae is separated by a disc, intervertebral disc. That's what these little cream-colored things here represent. So you got the vertebra here, the big blocky thing, then you got the disc in between. This thing down here is supposed to represent a herniated disc. All right, so you've heard of people saying, well, I got a herniated disc, and you've heard other people say, I've got a slip disc, right? And they're the same thing. It's kind of like the difference between a fracture and a broken bone. They're the same thing. What happens there is that the disc is made up, you can almost think of it kind of like a textbook or a phone book. So you got individual little bitty pieces of fibrous stuff that go together to create the book, right? But imagine your book having some jello on the inside of it. Jello is not going to come out until some of those pages are torn, right? So you're tearing up those pages and some of the goo that's inside the book comes out. And that's basically a slip disc. You know, where the analogy fails is that doesn't just leak out into the peritoneum. It's just this goo that is still attached, and we got to do something with it. So it's separated by the intervertebral discs, and they act as cushions so that you don't have bone on bone. So the disc is composed of the annulus fibrosus, which is the outer portion, and then you've got the nucleus pulposus, which is the inner portion. So a herniated disc is where you've got a tear of that annulus fibrosus, and some of the nucleus pulposus is coming out. And it's really not all that big of a problem until it becomes a problem. So what you've got is a disc that's going around all the way through in between the individual vertebrae. So if you've got a slip disc and it's pushing straight out front, then it's not pushing on anything. It's pushing on abdominal contents. Big deal. You got water pushing on water. It's really not all that big of a deal. And what this is trying to show is that if it's pushing back towards where it would mash a nerve right up against the bone, now you got a problem, right? Because the nerve needs blood flow, and if you compromise blood flow or stimulate that nerve, then you're going to have some pain. And the pain in a lot of cases is not going to be at the point of pressure because that nerve is receiving signals all the way down from your feet and your toes. So what a patient may experience, depending on where and how the nerve is stimulated, what the patient may experience is not pain here, but pain somewhere else. So you've heard of phantom pain, right? Somebody loses their leg and still their foot itches. Well, the reason for that is because the nerve is still intact proximal to where the amputation was. So the nerve still thinks the foot's there, right? So if that nerve proximal to where the foot was gets stimulated, like an itch on a foot, the patient will experience an itchy foot even though the itch isn't there. Kind of the same principle here. So if you get a mash of that nerve here, then the patient may have numbness in their toes or pain in their leg as opposed to actual pain, at the point of compression of the nerve. It's real weird. And we can predict where the patient's likely compromised nerve is based on what their pain is. If they're hurting on toes 2, 3, and 4, then it's probably going to be at one level. If it's 1 and 2, it may be at a different level altogether. So just a graphic of how the curvatures look. We've got 7 cervical, we've got 12 thoracic. Typically we're going to have 5 lumbar. Typically we're going to have 5 sacral segments, and then we'll have anywhere from 3 to 5 coccyx segments. Probably the most common deviation of this, not counting the sacral segments, are 2 things. One is, in a lot of cases, you'll see a patient with only 4 lumbar vertebrae. And it's an incidental finding. They had no clue that they had 4 lumbar vertebrae. And once in a while, you have a patient who has small ribs that stick off of the 7th cervical vertebra. You've got 12 thoracic vertebrae, 1 for every rib. So you should have 12 sets of ribs. But some patients, it's pretty rare. I don't know that I've personally ever seen it, but it's common enough that it makes its way into every textbook. And that is that sometimes patients will have what we call cervical ribs. And cervical ribs, in a lot of cases, the patient will have some upper extremity issues just because of the compromise or the compression of the nerve because of the ribs. So those 2 common, very common, or somewhat common spinal deviations. Probably the most common one that I see, though, is what we call a transitional vertebra. And a transitional vertebra, the cervical ribs is an example of transitional vertebra, but what you're going to see more often is what you'll have is L5 rather takes on the appearance of a sacral segment, but you've still got a disc there, so it's not really a sacral segment. It is L5, but it takes on the appearance of sacral segment, so it's got a very sharp curvature to it, or a very sharp wedge shape to it. So that's one. And number 2 is that sometimes you'll see L5 anterior to the anterior alignment of L5S1. In other words, L5 will be sticking out here somewhere. Again, incidental finding in most cases is what we call spondylolisthesis. And most of the time, the patient's not going to have any kind of problems with it. And it is an incidental finding. It just looks awful. It looks like what we call subluxation. Subluxation is where we've got one vertebra that slides anterior to the other vertebra. It's not a problem because our spinal cord actually ends right up here at L1, L2. It ends relatively high. You still do have the thecal sac below that. You've got individual nerves that come out in between the vertebrae, but the spinal cord itself is no longer existent all the way down here. So you don't have any kind of paralysis with spondylolisthesis. The patient doesn't have any kind of problems. And again, it's what we call incidental finding. It's something that we didn't expect to see, and it's not truly a problem for the patient. It's just that we happen to find something we hadn't expected to see. So typical vertebra, this is typical vertebra. We've got some that are normally atypical, but we've got a body. We've got a vertebral arch. Posteriorly, the body is anterior. All right, so the 2 parts enclose a space that we call the vertebral foramen. You're going to have a tendency to confuse the vertebral foramen with the intervertebral foramina. The vertebral foramen is the big hole where the spinal cord goes through. Vertebral, one vertebra, one hole, and the spinal cord goes through it. The intervertebral foramina are the holes where you've got 2 different vertebrae coming together to create the hole. Okay, so if it's intervertebral, that means 2. If it's vertebral, it just means 1. We got vertebral foramina where the spinal cord passes through all the vertebrae. All right, so the vertebral arch is formed by 2 pedicles, 2 lamina, and then you've got the articular processes that project off of and around the vertebral arch. So we're going back to the backboard again. So what you've got in the vertebra is this. And I'm going to draw this as if the patient's laying flat on their back. Okay? So the big thing that projects off of the back is what we call the spinous process. All right, so the spinous process comes up and it joins the vertebra and it goes anteriorly and laterally. And when it gets out lateral, just almost straight lateral, depending on which vertebra we're looking at, it goes outward again, and it creates what we call the transverse, because it's projecting out transversely. And then those go anterior, they go back towards midline, and then they go anterior, and off of the anterior of that, we create the body. Okay, so what we have posterior to the body is the vertebral foramen. So what we have here is what we call the lamina. The lamina is where the transverse processes come back to meet with the spinous process. That's the lamina. Up here, what we have is, again, word association, what we have is what we call the pedicle. Okay, so you can think of the pedicle as what's holding the body up. So word association, if you have something that you really like to take care of, something that you really want to display, you put it up on a pedestal. Exactly. So pedicle, kind of what the body is kind of what the body holds up. I just drew the vertebra for the elephant man, apparently. And what we've got is here the intervertebral disc. So that if the intervertebral disc, we get a rupture of the disc and it pushes back there, then what we've got is fluid-filled structures being pushed up against bone. You can't compress fluid. It just doesn't compress. Can you see okay? Okay, so you can't compress fluid. So the problem is that whenever we have an attempt to compress fluid, what we have is displacement. Okay, so you eat a great big meal and you lay down on your belly. You overate. At a buffet, you lay down on your belly. What kind of sensations do you feel? Can you breathe well? Most of the time, no. Okay. So what happens there is you lay down on your stomach, and all that fluid that makes up your abdominal cavity, plus all the food and the drink that you had, mashes up, and it's got to go somewhere, so it pushes your diaphragm up, and you can't breathe real well. So here, if the disc slips back and it mashes into the spinal cord, then what's going to happen is the spinal cord that might be shaped like that, if it continues to mash, what's going to happen is the spinal cord is going to be pushed into the bone, and then, of course, again, we've got some problems with compromised nerves. So what they'll do, anybody been to surgery? Nobody's been to surgery yet? Okay. Lumbar laminectomy where they were working on the back. Did y'all see that? You will eventually if you haven't. So what they do is, in some cases, they'll fuse vertebrae together. They'll go in and actually take the disc out, completely remove the disc and fuse a couple of bones. But sometimes a kind of a stopgap type things that's a less invasive surgery than a spinal fusion that might get them through is to relieve some of the pressure just by cutting a portion of the lamina out so that the vertebrae can actually bulge out that way a little bit. That's what we'll call a lumbar laminectomy. And the purpose for that is kind of to relieve the pressure in the event the patient has a bulging disc that's mashing on the spine and causing some problems. Okay? So, spinous process, transverse processes, body, where all those come together, we create the vertebral foramen. And the individual portions of the posterior arch would be, we've got the pedicle, which is just posterior to the body, and the lamina, which is where the space in between the transverse processes, and the spinous process. Don't just articulate at the disc space, but you've actually got some bony joint spaces in there as well. Okay. So can you see that line right there and there and there? Can you kind of make those out? If not, I can pass this out. But you've got articulations here. These are actually cartilaginous articulations, and it's what we call a facet joint, also known as a zygapophyseal joint. Zygapophyseal is the more accepted. Facet was what we called it for a long time. They changed it to zygapophyseal. Actually, they changed it to apophyseal, and then they added zyg in front of that, so now it's zygapophyseal joint. So if you've ever known anybody that had arthritis in their neck or in their back and they needed facet injections, that's what they're doing, is they're injecting some steroids into that joint space to relieve some of the pain in that joint space, inherent in the joint space. So what you've got there on each vertebra is a superior and inferior joint space. So back here you've got on this would be C, you got C1, C2, so you got C2, 3. So you've got a superior articular process, and then you've got an inferior articular process. So the superior articular process articulates with the inferior articular process of the vertebra directly above it. So that what you've got is vertebra with a facet joint, or facet, and then you've got another one, and they articulate together. So this is the inferior articular process of the vertebra on top, and this is the superior articular process of the one on bottom, and they come together like that. Okay? So you've got 4 of those on each vertebra. So you got 2 on top, 2 on bottom. Superior articular processes and inferior articular processes. Every type of exam that we're going to talk about, C-spine, T-spine, and L-spine, each one of those is going to ask you for 2 different things. On which view do we see the facet joint? On which view do we see the zygapophyseal joint? Or on which view do we see the intervertebral foramina, which is a foramina created by the articulation of 2 vertebrae that come together. So the nerves come out of the intervertebral foramina, right? Whereas the joint space itself is the zygapophyseal joint. So C-spine, we're going to see these on specific views and these on specific views, but they're going to be different. On the T-spine, we're going to see these on specific views and these on specific views, but they're going to be different. The same thing with the L-spine. Right. So pedicles project posteriorly, longus concave to form the vertebral notches, and the 2 vertebral notches from the vertebra above and below come together to create intervertebral foramina. And the foramina is where the nerves come off. Again, the foramen is where the spinal cord passes through. The vertebral foramen is where the spinal cord passes through. The intervertebral foramina is where the nerves come off of the spinal cord and eventually go down into the extremities, wherever it is that they need to go. So lamina project posteriorly from the pedicles towards the spinal process. So we talked about the transverse processes and the spinal process. Spina bifida is a condition where the posterior arch doesn't completely heal up, or it doesn't completely seal up. It's not that it's unhealed, it's just that it is unsealed. It should be fused eventually, but sometimes instead of coming together, in the posterior arch where they go like this, what they do is it's like they miss and they go like that. And most of your patients who have spina bifida don't even know it. Spina bifida is a congenital condition. You're either going to have it or you don't, and different textbooks say different things, but there's a condition called spina bifida occulta. It's like occult, like you're in a cult, but with an A after it. But anyway, that's a asymptomatic spina bifida that somebody in this class probably has it and you have no clue. A significant portion of the population, maybe, I don't know, different textbooks say different things, but maybe as many as 20% of the population has it. I might have it, I don't know. But it's asymptomatic, you'll live your life without even knowing it. Where it becomes a problem is if that separation between those 2 portions of the posterior arch are so great that a portion of the spinal cord comes out and the thecal sac comes out, that's when you have a problem with spina bifida. Okay, so spina bifida occulta is no big deal. Spina bifida, true spina bifida, what we think about when we think of spina bifida, most likely the patient's, there's a very good chance that there would be, if you had a spina bifida patient, paraplegic, right? So don't be surprised if you happen to see somebody that just is a walkie-talkie patient that comes in, somebody says, yeah, they have spine bifida. Most of the time, it's no big deal. So we talked about this. Those are your articular processes. Again, you've got body, you've got pedicle, you got if this is the superior aspect, that will be your superior articular process. You got transverse process. You got posterior arch with the lamina. And you got the spinous process. From the side, we've got the facet. Notice it says facet. Facet is just a place to receive something else. And usually, you don't see facet except for in two different places. Most of the time that we're talking about facets, we're going to see facet mentioned in only two places, and that is in the spine, really only one place, that's in the spine, but specific to articulation between the spines, the spinal vertebra, but also you got a facet out here. Now, every type of vertebra are going to have distinguishing markings to them, okay? So we've got a facet way out here on the transverse process, and that's unique to one specific portion of the vertebral column. We've got a facet here that articulates with the inferior articular process of the next vertebra to create the intervertebral arch. But we got this weird little facet right here and a facet right there, okay? And what those are specific to is a T-spine. So what do the T-spine vertebra articulate with that no other, unless you have, this transitional vertebra in the cervical spine, what do they articulate with that no other portion of the spine does? Ribs, right. So that's a rib facet is what those are. So the rib touches the body, and it also touches transverse process. So what's unique to the T-spine is that. So if you see on the test, vertebra, and it says, what kind of vertebra is this? And you see those two funky little spots right there, you know that that is only one type of vertebra. And that would be the C-spine, T-spine, L-spine. T-spine, T-spine vertebra, right. All right, so cervical vertebra, we've got 7. They occupy the neck. The unique features of the C-spine is that they've got a transverse foramina located in the transverse process. This is not the same as the intervertebral foramen. What we've got in the C-spine is blood supply that goes through the vertebra itself. You see this red thing right there? It's supposed to be representative of the vertebral artery that goes up into the brain. All right, so since you've got that blood flow going directly through the transverse process, you got to have a hole in the transverse process for the blood supply to go through it, right? So if you're looking at a vertebra, again, and you're looking at the superior or inferior aspect of it, and it's got a hole in a little bitty tiny transverse process, it's only going to be one type of vertebra that has that hole in the transverse process, and that would be a C-spine vertebra. Right. The other thing is that on the posterior portion, you probably can't see this from where you are, but on the posterior portion, on the spinous process, you've got a split. So snake has a tongue, it's bifid, it's forked, right? The spinous process on C-spine vertebra are also bifid, so that they, acute flexion and extension, you can get a little bit more extension if they're a little bit split. So two things that are going to be specific about C-spine vertebra. One is that transverse foramina, but the other is that the spinous process is going to be split. So just right at the end, it splits and it's bifid. So you got two in the C-spine that are truly unique. C1 is called the Atlas. In Greek mythology, the god that carries the world around on his shoulders, that's his name is Axis. All right, so C1 is the Atlas, the Atlas. C1 is the Atlas. It carries the head all right? And then the axis is C2. And the reason we call axis C2 is because it's got kind of like the book says it's like a tooth-like projection off the anterior portion of the body. And it's what we call the odontoid process. So it sticks up, and what you've got is the ring of C1 that fits right over the top of it so that you can pivot your head. Whenever you turn your head, most of that pivot comes between C1 and C2. You get a little bit of a turn between different vertebrae, but most of that pivot comes from C1 and C2. So that's where the turn comes from, is all the way up to C1, C2. C7 is also atypical in that it's got a great big long spinous process. So if you feel the back of your neck, that knot on the back of your neck, what you're actually feeling is what we call the vertebral prominence. Because it's prominent, it's that knot on the back of your neck is what you're feeling is the spinous process of C7. So what's unique about C1 is it has an anterior arch, it's got a posterior arch, it's got two lateral masses, and we'll talk about lateral masses later on. And we've got two transverse processes, but it has no vertebral body. It really doesn't have a body. What you'll see in the textbook, the drawing in the textbook, is it's a little bit expanded on the front, but it really doesn't have a body itself. Right? So it also has superior articular processes to articulate with the condyles of the skull. So on the bottom of the skull, wow, drop some of that and break it. The bottom of the skull, you've got these two condyles right here, and they articulate with C1. Right? So you've got articular process, kind of like facets on the top of C1 to articulate with the bottom of the skull. So again, off the front, you've got the dens of the odontoid process. So the unique thing about C2 is it's got a massive body, and off for its size. It's got a massive body, and with that body, it's got C1, so that it receives the odontoid process, sticks up through C1. So you've got kind of an axle type thing going on there, so that you can rotate the head. So C1, again, you've got this little bulge here, but you really fundamentally have no body. The posterior arch is very large, and really a portion of the brainstem sticks through there. You've got superior articular facets for the skull, and then you've got transverse foramen, whereas on C2, you've got the odontoid process, the lateral masses is just a big glob of tissue out to the side, or not tissue, but bone out to the side. Okay, now notice you've got a transverse ligament, and this is labeling the odontoid process, and it may occupy a little bit more room in the anterior portion of the arch. But the significance of pointing out this transverse ligament is that sometimes, we can have clinically broken bones without having a fracture, especially in the spine. So if a patient ruptures this ligament, and it can happen, then again, clinically the patient has a broken neck. This ligament, the purpose for this ligament is to keep the odontoid process in the anterior portion of the arch. So since you've got the spine right back here, if you don't have this ligament or this ligament tears, then what you've got is basically, your C-spine and your odontoid process can bump into your spine. Not a good situation to be in, right? So some of the exams that we take, it's vitally important to position properly so that we can evaluate the relationship of the odontoid as to where it's going to be, or where it should be. We'll talk about that when we get into broken necks here in a bit. So again, C7 is your vertebral prominence. You can easily palpate that. Typical vertebra, you've got the superior articular process. Again, you've got transverse foramen. You've got the bifid spinous process. You've got vertebral foramen, and then you've got the arches. You've got a very high arch on the bottom portion of one, a very low arch in the top portion of another, and those come together to create the intervertebral foramina. All right, we'll go about 5 minutes and then we'll take a break. All right, so patient preparation. With a C-spine, what you need to do is, if your patient's not in a collar, and you want to take the any necklaces off of the patient, or take any earrings out. If the patient's got any kind of dentures, you ask them to pull those out as well. You're going to have a problem sometimes if the patient's in a collar, and if the patient's in a collar, digging down to get to the earrings, digging around to get to the necklace. If the patient has a high likelihood of having some sort of cervical injury, probably pretty counterproductive. Because if you start digging around into the patient's collar trying to get their earrings, somebody starts poking on the side of your head, what are you going to do? Yeah, you're going to have a tendency to move your head a little bit, and if they've got a cervical injury, it's probably not a good thing to do, right? So sometimes you'll have to make a judgment call. If you've truly got a trauma and they suspect that the patient has a broken neck, then you're probably going to leave that stuff on or have somebody else take it off. Have the ER doc remove the collar and take that stuff off if it absolutely has to come off. But if the patient can, you want to remove all that stuff. Most of your positions are going to be subjective, and different techs will shoot in different orientations, whether they're upright or laying down. If they're a walkie-talkie patient, I do a little bit of a hybrid. Some of the exams or some of the views I'll shoot with the patient upright and some with the patient laying down, just because I get better outcome off of it. Your image receptor size, your column and field, for the most part, it's never going to be, for the C-spine, larger than 10 by 12. And really, the 12-inch length is pretty standard, but you can collimate in so that you don't include, you don't overexpose the patient. You can collimate side to side. So instead of 10 by 12, maybe 8 by 12. SID is going to be according to which exam we're going to shoot. Some are going to be at 40 inches, some are going to be at 72 inches. Always mark your markers. Your radiation protection, it's going to be hard to use radiation protection. You can put a gown on a patient, but it needs to be below the shoulders because that lead in the shoulders will show up. And patient instructions, most of the time it's just going to be exhalation, but some of the views we're going to have the patient do some, by the book, certain things, and we'll talk about those. So earrings, necklaces, any kind of clothing artifact need to come off the patient. Some upright, some with the patient's laying down. If it's a trauma patient, obviously you're not going to stand the patient up. You're not even going to move the patient if it's a true trauma patient. Uh-oh. All right. So we'll go ahead and take a break there, and then we'll come back and get into the rest of that information. I want to see. Okay, so I just made its way into this. Okay. Make sure I didn't open the wrong one. All right, let's take 10 minutes and then we'll pick up from there.